Respected senior leaders of ISA like Balabhaskar sir and Dr. Nasir sir, Shashi sir, Shenai sir, etc. And all other senior ISA members as well as my dear friends and colleagues. And first of all, I take this opportunity to thank the Malappuram City Branch for inviting me to moderate this session. That is such an important topic for us to hear. Especially Dr. Brijesh as well as Dr. Munish. Both of them are my colleagues. Dr. Munish was with me at Manjeri Medical College, and Dr. Brijesh is now working with me at the MES Medical College. And thank you individually to both of you for inviting me to moderate this session. And also, today's speaker is Dr. UMESH G, sir, and he is the professor and HOD of Dharwad Institute of Mental Health and Neurosciences, Dharwad, Karnataka. When we say about him, he has got more than 100 publications, and we are lucky to have the details that we can hear regarding the recent guidelines in the preoperative investigations from him itself. So we are so lucky. And the significance of this today's topic is that the PGs are still writing all the investigations without specifying the cases that they were seeing. They have got a pattern of investigations which they are writing to all the patients without any separation. So we have to repeatedly say them that you have to change, you have to do according to the requirement that is for this each and every patient, and we have to individualize the investigations to them. So now we can hear what the author says, and we start, and that is the recent publications. That is, I think that is published in May 2022. And also I invite Dr. UMESH sir to present this topic. And also Dr. UMESH sir.
Yes, madam. Good evening. Namaste.
Yes, good evening, sir. And also I welcome on behalf of the ISA Malappuram City Branch to this to present this topic.
Thank you, madam.
Okay, over to Dr. UMESH sir.
Hello and good evening. I am audible now, madam?
Yeah.
Yeah, okay. Thank you. Thank you, madam. It's a great privilege and honor to have this opportunity to present the ISA preoperative investigations guidelines. And at the outset, I would like to thank the office bearers of the Malappuram City Branch and all the senior faculty and the colleagues who have joined this particular gathering. Thank you very much. And I would like to brief you about why we brought about these guidelines related to preoperative investigation and the science behind that, the logic, and then what are the guidelines in the next 30 minutes. Yeah. First of all, we need to answer why do we need these particular guidelines when already there are so many guidelines related to preoperative investigations from the Western world. Why do we need it for our country specifically? That's because our country is such a unique country with significant differences in the geography, demography, socio-cultural, socio-economic significance is there. There is so much of variety. Starting from small setups such as primary healthcare centers or nursing homes to apex institutions, tertiary care centers, super specialized institutions. We have all the variety ranging from place to place, and anesthesiologists work in all these places, and the type of patients that they cater to will differ from place to place. Also, the infrastructure will be significantly differing from one place to the other place. So keeping in mind all these aspects and to curtail the practices of, as madam was just now suggesting, practicing ordering of battery of investigations without any logic behind the ordering of investigations. At the same time, to ensure that whatever investigations that we are going to bring about in the guidelines, they can be easily and uniformly followed across the country, even in smaller setups also, and keeping in mind the practitioners of anesthesia who are doing private practice, as well as the medical legal aspect. So we have focused on all these things, but yet when we call these as guidelines, they are not a set of practice patterns that are defined by a group of individuals. What we have done is evidence based guidelines. So most of these guidelines are completely evidence based, and only where the evidence is non-directional or there was non-consensus with experts. So the formulation of ISA guidelines was actually a brainchild of Dr. Balabhaskar sir, and it's really happy that sir has joined this meeting, and I invite sir to the meeting. It was his vision that India needs to have a separate set of guidelines for our country, and he went ahead and persuaded the present secretary and president of ISA for formulation of ISA guidelines, and then with their consensus, a core committee of 7 members was formed, and the core committee for preoperative investigations formed an expert committee of 16 subject experts who have been spread across the country, who have got academic standing in the anesthesia practice, and they have been picked up, and they have been made a part of this expert committee. Now the expert committee, along with the core committee, formulated certain research questions and then did literature review and prepared systematic review, and in consultation with statistician wherever applicable, meta-analysis was planned. And as a concise summary of all this hard labor is the guidelines, and they are evidence-based guidelines. The core committee consisted of Dr. S. Balabhaskar, Dr. S. S. Harsood, myself, Dr. Rakesh Garg, Dr. Zulfikar Ali, Dr. Sudesh K, Dr. Pradeep A. Dongare, and then the present president and secretary, Dr. Balabhaskar sir. Expert committee for preoperative investigations had 16 subject experts and 1 biostatistician. Now, this guidelines were published in the May issue of Indian Journal of Anesthesia, that is in the last month, and they published the methodology first, followed by the guidelines. So these guidelines are specifically applicable to the set of population ASA physical status 1 and 2 who are scheduled for elective surgical scenarios. Now, these elective surgeries may range from a simple debridement to an extensive laparotomy surgery. However, when we say these guidelines are applicable to these surgeries, so we are excluding specific organ-related surgeries like neurosurgery, cardiac surgery, thoracic surgery, vascular surgery, and transplant surgery. It's because they will have a particular organ or system involvement, and therefore that particular organ or system specific investigations need to be done, and the same cannot be extrapolated to the general population that we cater to for our daily anesthesia practices. And the main objective, the goal of bringing these guidelines was to recommend minimum required routine investigations that may influence the immediate perioperative outcomes or will in some way determine the anesthetic management. Either there may be a change in the anesthesia technique or monitoring or the medications that we use. In some way, it would influence the anesthetic management. Only then that would become important investigation to order. So when we say ASA physical status 1 patient, that is a normal healthy subject who is scheduled for a particular surgery. Since they don't have any comorbidity, unless they have certain addictions, usually whatever the investigation recommendations that are there in these guidelines, they become applicable to these patients. When it is ASA physical status 2 patients, they will have a certain comorbidity associated with. Can someone please mute the background noise? Thank you. So ASA physical status 2 patients will have certain comorbidities, though it will be a mild systemic illness. So they would be apt for going through elective surgical procedures. And in these patients, apart from the routine investigations that are recommended in these guidelines, the attending anesthesiologist should take a detailed history, evaluation, and review of medications and the previous lab reports related to the comorbidities of the patient, and use his or her discretion for ordering additional set of investigations over and above what has been prescribed in these guidelines. And when ASA physical status 3, 4, and 5 patients are there, since they will have severe comorbidity and they are not fit to undergo elective surgical procedures, they would go through specialist consultation for optimization, and they would determine further testing, further investigations, and optimization. So these guidelines do not intend to be applicable for ASA 3, 4, 5 patients. Also, when there is an emergency surgery, the emergency may be simple debridement or it may be a bleeding ulcer. So the patient where there is a debridement may wait for certain set of investigations to be done, and then you get the information and then try to optimize the patient and then take for surgery. Where a bleeding patient, you might have to rush the patient in and immediately take up for surgery. So individual patient's physiology may be different. One patient may be totally having normal physiology, other may be extremely dehydrated, one may be having metabolic acidosis, the other may be having electrolyte disturbances. A lot of variations will be there from patient to patient, and the urgency of surgery also will vary. Plus, the infrastructure in the setups may be different. So in such situations, the attending anesthesiologist, in consultation with the surgeon and considering the urgency of the surgery, should decide whether to order and what to order as a preoperative investigation, and whether to wait for those reports to come or proceed with the surgery directly, depending on the urgent nature of the surgery. Therefore, we have not brought the guidelines for emergency scenarios. We have given the freedom for the anesthesiologist who is attending the patient to take a call on this. Now, other debatable aspect is the screening tests, like viral markers, or maybe doing fasting blood sugar or serum creatinine. Underlying problem, because often we know that the patients for first time they would be visiting the hospital in their life when they are scheduled for a surgery. So it gives a unique opportunity to unearth some sort of underlying disorder these guidelines. The guidelines objective is very clear, that is to see if the investigation makes any significant difference to the immediate perioperative outcome of the patient, or it changes the anesthesia management plan. Only then the tests need to be ordered. Now, children, bariatric population, and obstetric population will have significantly differing physiology compared to the normal population that we cater to, and therefore these guidelines may not be completely applicable to these scenarios, and individual anesthesiologists need to apply their discretion while attending to this group of patients. Now, in the methodology, the inclusion criteria up to around 2010-12, we already had certain guidelines brought from other countries, and therefore we searched the literature from 1st January 2010 to 25th November 2021 for those studies which were published in full text in English, and those who had ASA physical status 1 and 2 patients and their details clearly mentioned, and those which concentrated on the objectives of our preoperative guidelines. Those studies were extracted and then they were filtered based on the inclusion criteria. If they were fitting to the inclusion criteria, those studies were taken. And any meta-analysis, systematic review, or narrative reviews, what we came across, they were searched for their references to find additional articles. So if studies had beyond ASA 2 patients, if a separate data set is available for ASA 1 and 2 patients who are scheduled for elective surgery, only such studies were taken. Where there was a mix-up of information between ASA 1 to ASA 3 or 4 patients, such studies were not taken into consideration, as ASA 3 and 4 status would have influenced the decision-making regarding investigations. Now, studies that were done purely with outcome as a cost analysis, they were excluded. The studies that did not mention ASA grading. In fact, we had several studies which were done by surgical colleagues regarding preoperative investigation, but the ASA grading of the patient was not mentioned, and therefore they were not considered for literature review. Now, studies related to cardiovascular, thoracic, neurosurgery, or transplant surgery were also excluded. Um, Now, during the evidence collection, the core committee initially prepared 10 research questions, and then we discussed that with all the 16 subject experts, and then refined those research questions and finalized them. And then each research question was allotted to a group of 2 or 3 subject experts, and then they did use certain search words to find suitable articles in Medline, Google Scholar, Embase, and Cochrane Library. And once they got the suitable articles, they were discussed with the core committee, and then core committee, along with those 2 to 3 subject experts for an individual research question, we prepared a systematic review and meta-analysis wherever possible. And then grading of each of these articles was done based on the grade protocol. And here we actually took the help of Dr. Gordon Gayat, who is from Canada, who is actually the father of this grade protocol. So we did have virtual Zoom meeting sessions with Dr. Gordon Gayat, and thankfully he had obliged and he helped us to grade these articles and helped us in systematic review. Now, the first hurdle that we faced during the preparation of systematic review was, if a patient is scheduled for a minor debridement, other patient may be scheduled for a radical surgery, malignancy surgery. Now, we cannot be having the same set of investigations applicable to both set of patients. So we had to divide the patients into certain categories. So how to categorize these patients? What we did was we requested our experts to give their anonymous opinion regarding the categorization of these surgeries. So the core committee collected or pooled about 35 to 40 commonly performed surgical procedures in general surgery, gynecology, orthopedics, ENT, and ophthalmology procedures. And we made a Google survey form and gave it to the subject experts. And they categorized them into minor, intermediate, or major surgery based on the invasiveness of the surgery and the duration of the surgery. Invasiveness was important because that would determine the amount of bleeding, hypothermia, and other problems that may be encountered intraoperatively, and the other complications. And the duration of surgery was also given weightage. So after they had more than 75% consensus with the expert group, we have categorized these surgeries as examples. Although a very exhaustive list of surgeries are there, we have given certain examples over here. And this is important because when we did systematic review, we considered this table for categorizing the surgeries that were performed in the studies that we evaluated, and based on that, guidelines were framed. Now, we had more than 60 meetings with the experts, and among the core committee, about 50, 60 Zoom meetings, all virtual meetings were there, along with a biostatistician. Also, we had about 12, 13 meetings. And then with Dr. Gordon Gayat, also, we had 2 meetings on a virtual platform. So overall, I think more than 2,000 to 3,000 hours of meetings have happened to arrive at the present recommendations. So when we say the path of evidence to recommendation is when there is a high level of evidence or more than one moderate level of evidence by grade protocol in a particular article or a group of articles, then the recommendation would be worded as recommended because it is a strong evidence. But when we have a weak level of recommendation, that will be based on the very low or low level of evidence. In such cases, suggested word will be used. This is uniformly applicable across the world. So we have followed the same strategy. Unfortunately, the preoperative investigation studies, there were no randomized controlled trials, and most of them were observational studies or case control trials, and therefore we have uniform recommendations using the word suggested. So they are weak recommendations. So as I was describing earlier, one research question was allotted to a group of 2 to 3 subject experts. So they had made the systematic review and we had made a draft recommendation. Now, just to make sure that the draft recommendation is exactly as per the evidence in the systematic review, we made this systematic review of all the 10 research questions pooled and handed over to all the experts. for each expert to see and identify whether the draft recommendations were perfect as per the evidence that we had given to them. And only after all of them had given their consent and agreed by three-step Delphi methodology that these recommendations were finalized. So the first research question that we addressed was, in ASA physical status, 1 and 2 patients scheduled to undergo elective surgery will routine preoperative complete blood count testing change anesthetic management or the patient outcomes after surgery? So these were the research question. And when we did evidence review, what we found was certain studies had addressed the complete blood count as a whole, while other studies had evaluated the components of the complete blood count, that is hemoglobin or hematocrit, total and differential leukocyte count, and the platelet count. And then we did a survey among the practitioners in the Indian Society of Anesthesia, and we found that through the survey that majority of our practitioners prefer to order complete blood count rather than individual tests, and therefore we made the recommendation for complete blood count and not for individual tests. So the recommendation 1 is preoperative complete blood count testing is suggested for patients undergoing minor, intermediate, and major surgery. So second research question was related to renal function testing. When we say renal function test, there are usually two components involved. One is blood urea and serum creatinine. The blood urea can be altered or affected by liver function and also during dehydration. However, serum creatinine is more specific to renal function, and even estimated glomerular filtration rate also takes into consideration serum creatinine, and therefore we have based the recommendations on the serum creatinine as it is a more specific marker for renal functions. So recommendation 2A is preoperative serum creatinine estimation is not suggested for patients undergoing minor surgery. Now, when we had pooled the evidence, we found that probably about 10 to 15 patients among thousands of patients who were involved in those studies had serum creatinine preoperatively ranging between 1.9 to 2.1, but the patients were completely asymptomatic. Just because the test was done, there was some abnormality detected. But when we saw the outcomes were not influenced in any way in patients who are undergoing minor surgery, and therefore it is not suggested for minor surgery. Recommendation 2B is preoperative serum creatinine estimation is suggested for patients undergoing intermediate and major surgery. The third research question was related to serum electrolytes. So most commonly we do serum sodium and serum potassium. So we evaluated for these. So the recommendation is preoperative serum sodium and potassium estimation is not suggested for patients undergoing minor, intermediate, major surgery. So irrespective of what elective surgery it is, there is no need to do serum electrolyte testing preoperatively, just like that in asymptomatic patients. However, it is in ASA physical status 2 patients, suppose there is an example, a patient who is a hypertensive, who is on angiotensin converting enzyme inhibitors or angiotensin receptor blockers or on diuretics may be there. So in such patients, serum electrolytes may be altered. So in such situations, the attending anesthesiologist should use his or her discretion to order serum electrolyte testing. Similarly, it may be ASA physical status 1 patient, but is scheduled to undergo a transurethral resection of prostate. As we all know, transurethral resection of prostate involves irrigation fluids which may be absorbed systemically to a variable extent during the surgical procedure, which can alter the serum electrolyte values, and therefore preoperatively ordering serum electrolytes in such patients would be welcome. So attending anesthesiology should use discretion where to order, but as a blanket for every patient, we should not order serum electrolytes. The fourth research question was related to liver function testing. The recommendation 4A is preoperative liver function testing is not suggested for patients undergoing minor and intermediate surgery because routinely doing pre-op liver function tests did not influence the outcomes in this category of patients. However, recommendation 4B is preoperative liver function testing is suggested for patients undergoing major surgery. So only for patients undergoing major surgery, routine preoperative liver function testing is suggested. The fifth research question is related to coagulation profile. In olden days, when I was doing post-graduation, BT, PT were also considered as part of coagulation profile. However, with the advent of auto-analyzers and them being available everywhere, now coagulation profile usually refers to prothrombin, international normalized ratio, and APTT. And therefore, we have based the recommendations based on the PT, INR, and APTT. Now, when we went through the literature, there were nothing supportive of doing these investigations routinely in asymptomatic preoperative patients. And therefore, the preoperative coagulation profile testing is not suggested for patients undergoing minor, intermediate, and major surgery. But at the same time, suppose if somebody is planning a central neuraxial block or even nerve blocks, and if you take a detailed history of the patient and review the medications of the patient, if you find that the patient is on certain Ayurvedic preparations or some medications which might influence the coagulation profile or even platelet counts, then the attending anesthesiologist should use the discretion to order for these investigations. But what we would suggest is you can refer to the recently published guidelines related to regional anesthesia and anticoagulation that are available in the literature. So based on those guidelines, the attending anesthesiologist can take a call on whether to or not to order a preoperative coagulation profile. Ayurvedic preparations and other preparations which do not belong to the allopathic medicine. In such cases also, we can refer to the recommendations related to alternative system of medications for doing coagulation profile. The sixth research question is something which is debated a lot, that is related to the blood glucose estimation. Now, if at the outset, I would like to clarify one thing. If a patient is a known diabetic, then definitely, yes, preoperative blood glucose is advised. There is no doubt about that. But in a non-diabetic patient, when we say non-diabetic patient, a patient whose clinical history, a detailed evaluation, and a review of medications and previous laboratory reports, if anything is there, none of that is suggestive of the manifestations of diabetic. There is nothing to suspect that this patient may be having diabetes. In such patients, whether blood glucose estimation is useful or not was the question that we wanted to address. So we did find 6 studies, and when we reviewed them, they all addressed non-diabetic patients. And the summary of that, the systematic review was very clear that in non-diabetic patients, pre-operative blood glucose estimation is not suggested for patients undergoing any of these surgical procedures. Now, the seventh research question was addressing 12-lead electrocardiogram testing. Again, if a patient is having some cardiac comorbidity like hypertension, maybe diabetes, maybe COPD, maybe some arrhythmias or some valvular disease, anything that can point to cardiovascular system pathology, yes, definitely 12-lead ECG preoperatively should be ordered. However, in a patient who is having non-cardiac status, that is, when we take a detailed history and clinical evaluation of the patient, then we review the medications and the lab reports of the patients or even previous ECG which might be there to the patient, and none of them suggest a possibility of a cardiovascular disease. In them, whether routine ordering of 12-lead electrocardiogram will make any difference to the patient outcomes or change anesthetic management. That was the question that we wanted to address. So what we found was, for minor and intermediate surgery, there was no evidence to suggest that ECG needs to be done. However, at the same time, we also looked at the evidence related to the cardiovascular diseases and the ischemic heart disease in our country. And what we find is, recently, India is becoming the capital of cardiovascular disorders, and by the age of 45 and above, quite a lot of people are having some or the other manifestation of cardiovascular disorders. And because the prevalence of cardiovascular disorders are increasing in Indian population beyond 45 years of age, recommendation 7A was made, that is, in non-cardiac patients, that means a patient who doesn't have anything suggestive of cardiac pathology, even then preoperative 12-lead ECG testing is suggested at age 45 years and above for patients undergoing minor and intermediate surgery. However, if a patient is scheduled to undergo a major surgery, irrespective of the age, a 12-lead preoperative ECG is indicated. The eighth research question was addressing the chest X-ray testing preoperatively. Now, when we discuss about the chest X-ray, India is known for a lot of pollution, active smoking, passive smoking, tobacco chewing, and also tuberculosis. So, with all these things, if we routinely order chest X-ray for patients, quite often we will end up finding some or the other minor pathology in the chest X-ray. But the question is whether that would influence the immediate perioperative outcome of the patient or the anesthetic map of the patient. So when we try to address these things, it is found that chest X-ray ordering preoperatively routinely does not really have any value. It doesn't add any value for patients undergoing minor surgery, and therefore recommendation 8A is preoperative chest X-ray testing is not suggested for patients undergoing minor surgery. However, for patients undergoing intermediate and major surgery, though there is no clear evidence to suggest that at the age of 50 years and above, chest X-ray would be necessary. Based on the expert consensus, seeing the experts from all corners of our country and taking their opinion, we came to a consensus. And so this was a consensus based recommendation, that is preoperative chest X-ray testing is suggested for patients aged 50 years and above undergoing intermediate and major surgery. The ninth research question was related to ultrasonographic evaluation of the airway for as a predictor for difficult airway. Now that the ultrasound is becoming more available to anesthesiologists, it has been added to the armamentarium of anesthesiologists, and many are becoming familiar with the use of ultrasound. We wanted to see whether the preoperative evaluation of ultrasound for predicting difficult airway would make any difference. When we did literature review in the defined period of 11 years, we had a total 22 studies which addressed this issue. And out of 22 studies, 20 studies were overwhelmingly in favor of ultrasonography for predicting difficult airway, because these ultrasonography airway parameters, what they had studied in these, they were definitely superior. They were more specific and more sensitive than any of the clinical parameters that we routinely evaluate in predicting a poor Cormack-Lehane grading, that is a Cormack-Lehane 2B or 3A or 3B. However, when we tried to frame the guidelines, what we found was that each of these studies had their own set of ultrasound airway parameters that were suggesting that they were superior to clinical parameters, but we could not narrow down to either 2 or 3 airway parameters which are common for all these 20 studies. And therefore, currently, considering also the Indian scenario, Indian context, where medical legal issues may arise because of many of our practitioners still don't have access to ultrasound, they don't have skills related to ultrasonography of the airway. Plus, even if ultrasonography is there because of PNDT Act, it may not be available in the preoperative area everywhere. So the current recommendation is routine preoperative ultrasonographic airway assessment is not suggested for predicting difficult laryngoscopy. Now, the last research question that we tried to address was related to validity time for previously performed investigations. The acronym VT-PIN was made for this purpose. In fact, we are really proud to say that this is the first guideline which has brought about validity time for previously performed investigations across the globe. Now, what we mean by validity time is, suppose a patient for some reason had undergone CBC, RFT, or ECG, or X-ray, some investigation a couple of months ago. Now, the patient is scheduled for a surgery tomorrow. Whether we can rely on that particular investigation or we need to order a fresh set of investigations. This is what we wanted to answer in this. And we found 2 suitable studies to answer these questions. In fact, one of these studies had evaluated ASAPS 1 and 2 patients scheduled to undergo elective surgery, and the patient population was overwhelming. It was more than 235,000 patients. And the other study also had near around 1,000 patients. So we had overall more than 236,000 patients database, and therefore the recommendation is the acceptable validity time for a previously performed normal CBC. Please note, normal CBC, normal RFT, normal LFT, normal coagulation profile is suggested to be 2 months, provided the clinical condition of the patient has not changed in the intervening period. That means, suppose 2 months back or 1.5 months back, we have done CBC, RFT, LFT coagulation profile, any of this, and they were normal. And in this 1.5 to 2 month period from the time of previous testing, the patient condition has not changed. Patient has remained totally stable. In such cases, yes, this recommendation is applicable. And if that previous investigation was normal and was there within the last 2 months, we need not have to ask for repeat investigation. We can rely on the previous investigation and go ahead with the scheduled surgery. Now, the recommendation 10B is the acceptable validity time for a previously performed normal 12-lead ECG and a normal chest X-ray. It is suggested to be 12 months. Again, provided the clinical condition of the patient has not changed in the intervening period. So, to summarize these guidelines, the complete blood count, you see wherever there is a green box, that means a test is indicated for that specific surgery, and wherever there is amber colored box, the test is not indicated or not suggested for that particular surgery. So complete blood count is indicated for all the surgeries. Renal function test is indicated, suggested for intermediate and major surgery. Liver function test is suggested only for major surgery. 12-lead ECG is suggested for patients aged 45 years and above for non-cardiac patients undergoing minor or intermediate surgery, and irrespective of the age for all patients undergoing major surgery. Chest X-ray is not suggested for minor surgery and is suggested for patients above 50 years and above of age undergoing intermediate or major surgery. However, if a patient has any cardiac issue, we can order the ECG earlier or at any age. And similarly, chest X-ray, if a patient is symptomatic, we can order chest X-ray for symptomatic patients prior to 50 years of age. And the validity time for blood investigations, normal blood investigations, is 2 months. For chest X-ray and ECG, it is 12 months. This is in summary. Serum electrolytes, coagulation profile, and blood sugar, they are in the amber box for all the surgeries, and therefore they need not have to be routinely ordered, but attending anesthesiology should use their discretion based on proper clinical history, clinical evaluation, and then review of medications and the previous reports. They can take a call on additional investigations. Thank you. Any you can type in the chat box, and we would be happy to answer them. Madam, you are muted, madam. Shamshad, madam. Madam, you are muted. Brajesh Verma, sir, you are host, you can unmute.
Yeah. I was muted, sir.
No, that madam is still muted.
Just a minute, sir. I'm doing it.
Okay, ഇനി അവർക്കെന്നെ ചെയ്യാം. Okay, everyone.
Yeah. Okay. Now it's unmuted. Okay. Thank you, sir, for such a brief presentation of a large system of investigations, as well as the publication that you have made. And it was so helpful, and it was the simplicity that you have explained. And one thing that I have to ask is, any questions in, okay, shall I see? Sir,
Yes.
Dr. Jitendra has asked whether the thyroid function test is required or not. Sir, Umesh, sir? Can you hear, sir?
Madam, yes, I was trying to type the answer. Yes, I was trying to type the answer. I'll just discuss here.
Okay.
Comes under my intermediate surgery. Am I audible?
Yeah. Yes, sir. Sir, yes, it is audible.
Hello.
Hello,
Yes,
sir.
sir.
Am I audible, madam?
Yes, sir.
Yes,
You are
sir, you-
audible. Yes, sir. You are
Hello?
audible. You please explain, sir. What about the
Yes,
status of
okay,
the
fine.
thyroid function test?
Okay, right, madam. Yeah. Yes. So when a radical thyroidectomy or total thyroidectomy is scheduled, it is a major surgery, and in major surgery, yes, liver function test is to be done. So if it is a simple benign thyroidectomy, hemithyroidectomy, it is an intermediate surgery and it is not indicated.
The thyroid function test. Is it,
Yes,
sir?
madam. No, it is liver functions.
Yes.
Question is about liver functions, madam. Liver
Regarding
function
the
test.
thyroid function test, Dr. Jidendranath
So
Krishnan.
thyroid function.
Yes, thyroid function test, whether it is indicated or not.
Yeah, in a patient who has a thyroid disorder, thyroid function tests are indicated, madam, because it is
Yes.
that particular organ
Okay.
that is involved. Yes.
Okay, sir. And also the other one is the regarding the liver function test. That is, would you LFT for a thyroidectomy?
Yeah, that's what I try to answer, madam.
Yeah. Okay.
If it is a benign thyroidectomy, hemithyroidectomy, it is an intermediate surgery. So liver function test routinely is not indicated. But if it is a radical thyroidectomy, total thyroidectomy, along with maybe parathyroidectomy, in such cases, yes, it is a major surgery, and therefore liver function test is indicated.
Okay, sir. The next question is platelet count or PTINR, which is better for spinal anesthesia. I don't know who is this GSPK. Who is it? Can you please say your full name, please? That it is whether PTINR is indicated or the platelet count, which is better in for giving spinal anesthesia.
Regarding this coagulation profile per se, when regional anesthesia is considered, we don't have any particular recommendation for that. However, we have suggested that the current regional anesthesia and anticoagulation guidelines need to be referred for that. As a routine investigation, yes, platelet count becomes a part of CBC, and therefore CBC is already done for every patient undergoing surgery. But PTINR need not be done if a patient is asymptomatic, is not on any medications that might alter the coagulation system. But if regional anesthesia, especially central neuraxial blockade, is planned and the anesthesiologist feels that maybe it is wise to do a particular coagulation profile testing based on their evaluation, they can consult the regional anesthesia anticoagulation guidelines.
Only if it is indicated, only we need to do the platelet count as well as PTINR. Is it, sir? Only if it is indicated in a patient with a coagulation abnormality. If you are expecting it, then only it's indicated. Otherwise, for ASA grade 1 and 2 patients, it's not recommended, as you have said. Can you hear, sir?
Umesh?
Can you hear, sir?
So I think till he joins, I can continue the discussion. Umesh, you are back?
Yes, sir. I can hear you, sir. But madam's voice was interrupted. I couldn't.
Yeah, madam had a question. Please, madam, you can repeat to him.
Sir, it is the platelet count and PTINR is indicated only for indicated cases alone. That is not for as a routine test. Yes, just like that, that we are usually practicing, isn't it? Sir, if we are doing unnecessarily platelet count and PTINR, sometimes may come as abnormal. So when we repeat the test, it is found to be normal most of the time.
Yeah, unless and which one to rely becomes an issue.
Yeah, okay.
Yes, madam. In fact, when we see the normal range of laboratory values, they are determined, as 95% range in apparently healthy subjects. That means even in a apparently healthy subject, 5% of the lab values may fall outside this range. So it might appear like it is abnormal for that individual, although the patient perfectly may be normal physiologically.
Sir, another question that asked by that sir is, TURP, will it belong to intermediate or major surgery?
Yes, madam. Our experts have defined it to be under intermediate surgery based on both the invasiveness and the duration of surgery.
Okay. Then
This was based on the expert consensus.
Yeah, okay, sir. And Mangesh sir has asked, is CBC is indicated for ASA grade 1 and 2 patients?
Yes.
Good evening, sir. Yes, sir.
Sir, you can directly
the guidelines
ask.
State. Yes, CBC is indicated for ASA physical status 1 or 2 patients who are scheduled for whether it is minor surgery, intermediate surgery, or major surgery. Irrespective of that, any elective surgery, CBC is indicated, sir.
Yeah. But how it is going to change your way of anesthetic management in ASA 1 or
Yes,
2
sir.
for
We
hernia
had
or hydrocele?
yes, sir. We had more
Because
than 25,000 patients in a particular study. So which had intermediate surgery, and that particular study had total leukocyte count and differential count really affecting the outcomes of the patients. So based on that data, we have formed the guidelines.
Okay.
Sir, just to supplement what Dr. Umesh is telling, so we have included mainly ASA 1 and 2 patients.
Yeah.
Number 1. Number 2 is selective patients. Emergency we are not dealing because emergency surgeries, there are some peculiar problems both in terms of pathology and the surgery part. Then on was we looked for all the evidences. Even for example, as an individual, I will not be happy with some other recommendation as an individual anesthesiologist or a practicing anesthesiologist. But when we formulate the guidelines, we totally depended upon the evidences. Number 1. And in fact, Dr. Umesh talked about how we did it and where we had a problem with evidences, but we were expected to address some of the issues which are discussed even now in this forum now today. We had a system called Delphi consensus. It's again accepted internationally as part of guidelines formulations. For example, as Umesh was telling, we use what is known as a grade protocol created by the World Health Organization. Number 1. So where we did not get evidence, we depended upon experts and by a process called Delphi consensus. So they will not only talk about evidences or lack of it, but based upon their experience, they will also give their input, and it is scientifically accepted worldwide. So that way, some of the recommendations were based on that. And when we talk about ASA 1 and 2, we talked about, we did not talk about spinal anesthesia. And because there was question, for example, somebody asked about PTN or somebody, why not platelet alone or something like that. So our problem was with respect to the outcomes which were taken as part of our guidelines preparation, whether a particular investigation will affect the outcome of the surgery, whether the particular investigation will affect the type of anesthetic procedure we conduct, and whether it is going to disturb our anesthesia practice. So these were largely the outcomes which were taken up by us and which were also done by many guidelines from across the world. So that way speaking, sorry, there are some tractors being burst out of the hospital on the main road.
Okay, sir. Thank you, sir, for your explanation. And
Another, madam,
yeah.
just 1 second.
Okay.
Yeah, one
Continue,
more.
sir.
Yeah, we had also evaluated the prevalence of anemia in preoperative ASA physical status 1 and 2 patients in India. So we had 6 from India, and from that prevalence of anemia in preoperative ASA physical status 1 and 2 patients, who are scheduled for elective surgery was nearly 14%. I think 13.64% it was. So that was also one reason why we decided, otherwise we could have done only hemoglobin estimation or TLC estimation, but then our practitioners, majority of them felt ordering CBC rather than individual components. They were in favor of CBC, and so the guideline was made for CBC.
Okay, sir. Yeah, I think it is better to rule out the infection status also. CBC will give.
Right.
Yeah.
Yes, ma'am.
Yes, sir. And another is by Nasir sir has asked about is it going to be accepted legally whenever some cases have occurred?
These are evidence-based guidelines, madam, except for
Guidelines,
the
okay.
chest X-ray recommendation. All others are purely evidence-based, and therefore, definitely, rather than one person's, opinion over the other person's opinion about a particular investigation to be done or not. When in legal system, what happens is they call one expert and ask them. So they would just go by what they are practicing, and they would say whether something needed to be done or not done. But these are evidence-based guidelines, and therefore they are applicable across the country, and they definitely will have legal acceptance.
Sir, the problem is that whenever in a mortality case or morbidity case, it comes when so many of the experts are coming, and at the same time, one public prosecutor will also be coming, and they will be bringing our textbooks, and they will be referring that only. So in such cases, we have to make them, I think so, we have to give them the directions that as per the newer guidelines, we are following this. In that case, what Nasir sir has told may be accepted. Can we say like that, sir? Because the public
Definitely, madam.
prosecutor is the main person who is bringing all our textbooks and also all the references. So that's the problem.
Because of lack of Indian guidelines that they could do that.
Yeah.
So now
Okay.
we have Indian guidelines. So, and they are evidence-based, purely evidence-based. It was not a collected opinion of 10 or 15 people. They were completely based on evidence. And we can show this, that these are the evidence-based guidelines, and they will definitely accept it.
Okay, sir. Thank you. And
Hey,
one
madam.
more question. Can we? Yeah. Okay.
Yes, it will be
Yes,
ideal if this has come in some of the standard textbooks, at least some textbook from India, or it will be accepted by the government bodies like NMC, then it will be more acceptable. If we can try for that.
Yes, sir.
We can present it for NMC, these guidelines. But unless all of our textbooks are from the Western countries, since it is not coming in that, till that time, we have to make them aware of that. These are the Indian guidelines, just like our IRC guidelines. We can recommend like that. I think so.
Yes, that's
What about sir, Balabhaskar sir? What's your, yeah.
Yeah. Yes, sir, still.
Yeah, sorry, I had muted because there is second cracker sound continuously coming. I was listening to the discussion. Yes, it is legally, it is recognized because it's not a consensus statement, it is not an expert statement, or it is not, we call it some group of experts talking about it. It is an evidence-based guideline. It will be supported and taken, the court will take notice of these guidelines. And in fact, all these years, the problem was, now I will not say that we are totally 100% protected. You know how the system works. The lawyers have to put our case forward properly. We have to fight our case properly. And majority of the times, it is the record keeping where we fail. We fail in maintaining the records. So I will not go into those details. So basically, the courts were also asking, where are the Indian guidelines? When they asked a lawyer from our side, they will ask us to get the evidences. So all the evidences so far we had were American, the European, the Australian guidelines only. And now, as UMESH was telling in the beginning, it is more customized to Indian practice also. And we have taken care to see that our practitioners are not affected. Actually, the private practitioners, the freelancers. In fact, if you look at the ultrasound with respect to the airway, We have got very strong evidences which are there in the last 5 years, and they keep on coming every month. But we have not touched upon it in the form of a good recommendation or a strong recommendation, mainly because the availability is still a problem in India, then the cost is a problem in India, and number 3, we also get to have some experience and expertise in that. So we skipped that part. So we only said it is a matter for recommendation in future. Probably in next 5 years, when we are economically strong and everything is available, we'll be talking about mandatorily having an ultrasound for airway difficult laryngoscopy assessment. But we had so much of evidence that it is very useful for assessing a difficult laryngoscopy in the patient. So that was the way we decided, and especially this another important one was the VT pin. The validity time for previously performed investigations. So they were also soundly based upon evidence.
2 months.
Yeah. So that was also nicely done from our group, madam, and definitely all of us can share. That's the reason I said I was very happy when you had this program from your branch, from Malappuram branch. So all of our branches, the state branches, of course, national also will do. And I think I requested the SARC group also to do it. So we have to project our guidelines. And
Sir, we have already,
we have
already started practicing this in our college.
Yeah. So
this is the screenshot that is made by our one of our professor, Dr. Abda sir, and he has given it to me that we have to show it. That is expect
we are ready to share the presentation, madam. Dr. Umesh will share the presentation in a PDF format, so that can be used for teaching purposes and anywhere by any of our members, no control, so that we propagate these guidelines also. That's the important part.
Okay, sir. I think that is this is the correct one. That is, we have to individualize the patient, and only after that we have to recommend the investigations. I think so, sir. And we can practice that also once we have practicing it as the Indian guidelines. That is the ISA, Indian Society of Anesthesiologists guidelines. We can recommend that also, sir. Because especially in the for the freelancers, if they were doing all these investigations, that will be affecting the cost of the patient, and that will be compromising their management like that.
Yeah, we have. If you look at that the display you showed me.
Yeah.
So that is very explanatory, and we are not loading the pressure. Putting pressure on our practitioners at all. So, for example, very simple CBC is, if I want to order hemoglobin, the lab will not give hemoglobin. The lab will give everything in that sheet, CBC. It has got TC, DC, platelet count and everything. So we also consider those aspects. We also discussed with the pathologists also and laboratories also. And then we came to and of course the experts, the Delphi consensus. They said if it is so it is definitely advisable to talk about CBC rather than hemoglobin. And you get platelet in that also, basically as part of that. And practically, so we also thought about the practical application of these guidelines for a private practitioner. So he would say CBC.
Yeah.
So very simple. And anyway, majority of the private hospitals do that, and surgeons by default would have done that. So there are some considerations that some of our colleagues said before we go and meet the patient. Already many of the investigations are done, and many of unnecessary investigations are done. So best thing is we'll not go into those details. Unnecessarily electrolytes are done. Unnecessarily, many of the cases electrolytes are unnecessarily done. And we are not talking about urea at all. If you look at our guidelines, urea is not mentioned. We are only talking about creatinine, because we are able to get indirectly the GFR, eGFR by creatinine levels, and creatinine level is independent of the age and the muscle mass and other things. And so we have taken it scientifically. So we'll talk about CBC, we talk about creatinine for the patient, we talk about PTINR. So that way we have taken it forward.
Sir, is it applicable for the pediatric patients also? Pediatric cases, that is when they come for surgeries and all. And we are doing only the blood count alone. Yeah. So most of the time we will be giving some caudal and all. So nowadays we are not even doing the bleeding time as well as the clotting time.
Yeah.
Whether it is
So-
indicated, sir?
No, yeah, it is indicated if you take my opinion, but we have not talked about this as part of the guidelines.
It's
Basically,
not
when-
come, it has come came in the guidelines.
yeah. Mainly because it was again extraordinary set of evidences which are available, and there are a lot of what we call as confounders in between for the pediatric patients. So that's the reason we then stopped. Actually, we had taken it forward. In the middle, we stopped. In fact, we had a pediatric anesthesiologists who are experts. No, they are purely into pediatric anesthesia also. We took their services, but ultimately all of us together said that we will not talk about it.
Regarding
So
the
purely
pediatric.
about the pediatric patients. Because we have got the considerations of physiology related to pediatrics, and there are some of the conditions which are concealed in pediatrics, they become revealed during the actual anesthetic management. So that's the reason we have put the most minimum investigations, and it is the discretion of the attending anesthesiologist based on the history, examination, review of the previously performed investigation, and the drug history of the patients. So these four things, it is still the responsibility of the attending anesthesiologist to take the guidelines in a proper perspective and add additional investigation if necessary. So that
Okay,
way,
sir.
that burden is still there on us. We cannot say that I will do everything for all the patients. Nazar sir.
Okay. Thank you, sir. Yeah. The next question is by BRS, that is to everyone. Can we start teaching these recommendations to our medical colleges? So already we have started it, and in government medical college. Yes, in government medical college also we are doing the minimum investigations now, because all the PGs, when they start coming in, they are listing all these investigations. And most of the time what is happening is they will be postponing the case. Sometimes if it is not indicated, sometimes it comes as abnormal, then we have to postpone the cases because it will be documented in the case sheet itself. So now we have changed the practice of doing all these investigations only for indicated one. And sir, Mangeshanai sir and Shashi sir, Nasir sir, all of you can also give your opinions also, sir.
Can I speak?
Yeah, okay, definitely.
LFT, sir, which are the components you give stress on? If we are doing all the components, it will be the cost will be very high.
Sir, when we evaluated the evidence for minor and intermediate surgery, we had an overall pool of more than 26,000 patients. So in them, individual components of LFT were studied, and none of them had any influence on the outcomes or anesthetic management. So it is not indicated for minor and intermediate surgery. But when it is related to major surgeries, we did not have studies that evaluated individual components of liver function test. We had only mention of liver function test, whether it alters the outcome or not. That much information only was available, sir. So as of now, I think we have to order full LFT in major surgery because we could not get information related to individual components.
Even in that, it is in a major thyroid surgery. If you are doing albumin, bilirubin, and everything, it will be cost will be very high. We can get it is not the same as CBC. We can get the picked up values. If there is any abnormality in bilirubin, we can ask for this other components, albumin and alkaline phosphatase, etc., gestin, etc. So otherwise, the total LFT test will be very costly.
Sir,
That's
only
the problem.
for radical thyroid surgeries that liver function test will be necessary to be ordered routinely, and in them we really did not have evidence for individual components. So because of that shortcoming, we could not answer this particular part, that whether doing only bilirubin or only albumin to start with and then consider if they are abnormal, to consider other investigations. Sorry, sir, we could not get evidence, so we had to bring in recommendation for whole LFT. Though it may not be cost effective, but based on the evidence, we could only bring it for whole LFT in that scenario.
Thank you, sir. Thank you, Malappuram sir, Umesh sir, for
Yeah,
this presentations. And
yeah.
Rajesh for
One
also
more.
for
Sir, one more question is there. Jitendra Nath asked about the lipids. What he meant for the lipids
Lipid
means
profile,
lipid profile maybe.
maybe, yeah. So this is again, madam, if for somebody's cardiovascular history is there, then usually they will be referred to a specialist for further evaluation. They can probably consider whether lipid profile is needed or not. We don't routinely advise lipid profile for patients. So actually, we did not evaluate this part, lipid profile, as a part of our research question. But just as our own opinion, I feel the cardiologists are the ones who would be usually asking for this when we refer the patient to cardiologist.
And the presence of a hypertriglyceridemia or whatever, again, it doesn't fit into our outcome parameters. So would hypertriglyceridemia would affect the type of anesthesia I choose? Would it affect the anesthetic outcomes? Definitely it's not there. So that way, so it's not going to help us in terms of a single finding on a lab investigation. So we would expect the patient to be, for example, obese. The patient is obese, definitely considerations related to obesity would come, and there will be cross consultation many of the times with the cardiologist also. So per se, in the absence of such obesity or cardiovascular diseases, there is no indication for performing routinely the lipid profile as a preoperative investigation. And we did consider about the packages, which is very common in many of the corporate setups, where they talk about package 1, package 2, and package 3 are different varieties for the preoperative period. So we picked up the packages from different areas, and then we discussed with our experts also. And even our experts who were part of some of the corporate groups were also totally against it. So they were forced to use it, but they were not definitely inclined to use the package system. Number one, because it was not scientifically correct. And number two, it was unnecessarily imposing an economic burden on the patient. This is another aspect which was also picked up by us.
So unless it is indicated, lipid profile is not recommended. That's what says.
Yeah.
Is it? Is it,
Yes.
sir?
Yes.
Yeah. I wanted to say one thing.
Yes,
May
sir.
I?
Yes, sir.
Yeah, of course, sir.
Yeah, regarding cardiovascular system, as you have said that where the ECG is normal in prior 2 months, and if there are no fresh changes, fresh symptoms, we did not go ahead for the fresh. Similarly, I would I also like to add, many times patients who come to you might have undergone angioplasty. And I feel that those patients who have gone on angioplasty in last 5 years, and within 5 years, if they don't have any fresh symptoms or signs suggestive of another episode of cardiovascular problems, they need not be subjected to any test for that if they are not having any symptoms within last 5 years.
So that,
no.
Sir,
No need to go
related
for
to
angiogram or echo.
electrocardiogram, sir,
It's
electrocardiogram
angioplasty.
specifically.
no, angioplasty. Sorry, it's talking about angioplasty done about 5 years ago.
Yes.
And
In a patient with angioplasty
Reason will be.
who has undergone angioplasty, let's say 2 years ago. Now the ECG was available 2 years back, and the patient is completely asymptomatic or totally symptom-free and leading a healthy lifestyle. But yet, based on the evidence, after 12 months, it needs to be repeated, sir. Because it is a patient with some cardiovascular disease, and we don't know how the progression of the disease is happening.
Better to have a recent disease.
No, I had read that if patient has undergone angioplasty, say last 5 years ago, and within those 5 years, patient has no aggravation of any symptoms, or patient is having absolutely normal life, after that you need not subject him to any further investigation. That is what I did. I do not know whether if it is changed now.
So we will look through the literature once again for this particular aspect.
Oh, yeah.
That's basically
Because it's a
purely
costly
cardiac.
investigation also.
Yeah, no, purely cardiac, no, sir, pathology related guidelines. We refrained from commenting about that because
Okay.
it's a separate domain, cardiovascular status condition.
Ah.
But for example, AHA guidelines, which are already there with respect to the cardiac condition, AHA, ACC guidelines are there.
Yeah.
So that's the reason we didn't touch upon the cardiovascular system. Similar to talking about the anticoagulants with regional anesthesia.
Yeah.
So that's the reason we didn't talk, because there will be some clash of evidences and other things. So that has been clearly declared. Yes, sir.
Okay.
Okay, sir. Thank you very much to all of you for having a very good discussion, as well as for the nice presentation that UMESH sir has presented, as well as we all are thankful.